Hello and welcome to the Annals of Internal Medicine podcast. This is Dr. Christine Lane, Annals Editor-in-Chief, and I'm eager to share highlights from the June 19th, 2012 issue with you. But first, I want to mention a few online first publications that have appeared since our last podcast. If you have ever spent the night as a patient in the hospital, chances are that it sounded a lot like this.
Dr. Rondelson, please come to the front desk immediately.
Adequate sleep is imperative to the healing process. Physiologic effects of sleep disruption include hypertension, impaired immune function, elevated stress hormone responses, cognitive deficits, and depressed mood. However, noise frequently disrupts the sleep of hospitalized patients. In a recent national survey, patients reported that noise levels in and around hospital rooms at night was an important factor in poor quality of care ratings. To better understand the types of hospital noise that is most noxious to sleep, a study that Annals published online first on June 11th evaluated 12 healthy participants in a sleep laboratory setting to determine whether specific hospital noises and at what levels disrupted sleep according to type of sleep stage. Sleep stages included REM, or rapid eye movement sleep, and the 3 progressively deeper stages of non-REM sleep. Over 3 nights, patients in the lab were exposed to hospital-recorded acoustic stimuli, the noises that I played for you a little while back. Noises included those that were external to the building, such as airplane and street traffic noises, those that were within the hospital, telephones, paging, and medical equipment alarms, and hallway noise, conversation, ice machines, laundry carts rolling by. Not surprisingly, the researchers found that louder sounds were more apt to cause sleep disruption, especially those that were engineered to alert, like alarms. However, noises such as ice machines, laundry carts, and overhead paging woke study subjects at relatively low sound levels. Patients able to achieve REM sleep before the noise started were less likely to awake. These observations demonstrate that hospital noise does result in sleep disruption, even in healthy volunteers. It is conceivable that the problem is worse in people who are ill and have other reasons for poor quality sleep as well. Noise reduction in hospitals could be an important factor in improving patient care. Noise-conscious policies, procedures, and building design could lead to improved patient sleep, better quality of care ratings, and possibly better patient outcomes. Osteoarthritis of the knee is a common and often debilitating condition. Among the physiologic findings in osteoarthritis are changes in joint fluid that compromise the cushion the knee joint needs to function properly. Typically, non-steroidal anti-inflammatory drugs are prescribed for patients with osteoarthritis to reduce pain and restore function, but relief is often limited. Intra-articular injection of hyaluronic acid, also known as viscosupplementation, is an alternative treatment option for osteoarthritis. The intent of viscosupplementation is to replace joint lubricants. A systematic review published online first on June 11th evaluated 177 reports describing 89 trials to assess the benefits and harms of viscosupplementation for adults with symptomatic knee osteoarthritis. The researchers found that the benefit of viscosupplementation on knee pain and function in patients with symptomatic osteoarthritis was minimal with respect to pain and non-existent with respect to function. Yet, adverse reactions following viscosupplementation were common and could be serious. In addition to local inflammation and consequent symptom flares, some patients experienced adverse events related to the gastrointestinal system, cardiovascular system, cancer, and musculoskeletal system. The evidence of low efficacy and increased risk of adverse events should discourage physicians from administering viscosupplementation injections and patients from seeking this treatment. Now on to the June 19th issue. It is well documented that patients with alcoholic cirrhosis are at increased risk for hepatocellular carcinoma. However, whether screening patients with alcoholic cirrhosis for this cancer improves their health outcomes is uncertain. The first original research article in the June 19th issue reports a study from Denmark that followed a cohort of patients with alcoholic cirrhosis to evaluate their risk for hepatocellular carcinoma and overall mortality. Among 8,452 patients with alcoholic cirrhosis in the registry, 5,734, or over 43% of patients, died within 5 years of follow-up. Yet, only 1.8% of the deaths were related to hepatocellular carcinoma, so hepatocellular carcinoma contributes very little to the high mortality rate in patients with alcoholic cirrhosis. These data suggest that, despite the elevated risk of hepatocellular cancer that occurs in patients with alcoholic cirrhosis, screening these patients for this cancer is unlikely to have any noticeable effect on overall mortality. Often patients suffering from Alzheimer's disease take a turn for the worse during hospitalization and fail to return to their pre-hospital baseline following discharge. The next study reported in this issue comes from a large prospective registry of patients with Alzheimer's disease. The researchers found that hospitalization was associated with a substantial increase in the risk for death and institutionalization. Patients who experienced delirium during the hospital stay were at heightened risk for these poor outcomes. Whether it was the hospitalization itself or the underlying reason for the hospitalization that was responsible for these observations is uncertain. Next is a case series that describes 4 adults who developed symptoms and signs of liver injury within 3 months after initiating flavocoxib. Flavocoxib is a proprietary medical food that is marketed to treat osteoarthritis. A medical food is a specially formulated supplement used to manage diseases with specific nutritional requirements that theoretically cannot be met through normal diet. Unlike drug treatments, medical foods can be marketed without clinical trials proving safety and efficacy. In this case series, the authors describe characteristics of patients with acute liver injury that is suspected to have been caused by flavocoxib. Among 877 patients enrolled in the Drug-Induced Liver Injury Network prospective study, 4 developed symptoms and signs of liver injury within 3 months after initiation of flavocoxib. The 4 patients, all females between the ages of 57 and 68, were evaluated to determine the likely cause of their liver injury. The researchers concluded that flavocoxib was very likely to be the cause in 3 patients and was possibly the cause in the 4th. For all 4 patients, the liver injury resolved within weeks of cessation of flavocoxib. In an accompanying editorial, Dr. Stephen Reichenbach and Peter Juni observed that patients often consider medical foods and food supplements to be natural, so they may not disclose use of medical foods to their physicians. The editorialists caution that physicians should discourage their patients from using any kind of medical food or supplement until policies related to marketing are changed to include safety and efficacy trials. They write, "Given the widespread use and potential harm of medical food and food supplements, the policy of marketing these products in the absence of clinical evidence needs to be reconsidered." The next 4 articles in the June 19th issue may be familiar to some listeners from when they appeared online first on annals.org. First of these articles is a systematic review that evaluated available studies of the benefits and harms of drugs for urinary incontinence in community-dwelling women and found evidence that rates of continence and clinically important improvement in urinary incontinence were greater with drugs than with placebo, and that the various drugs appeared to have similar effectiveness. However, improvements were modest, and drug discontinuation due to adverse effects was very common. Shortcomings of available studies included inconsistent definitions of improvement in incontinence and a lack of evidence on long-term adherence and safety of treatments. A CME quiz accompanies this article on annals.org. Next is an update that summarizes studies published in 2011 that the authors consider highly relevant to the practice of hospital medicine. Topics include acute decompensated heart failure, pulmonary embolism, atrial fibrillation, telemedicine, cardiopulmonary resuscitation, chronic obstructive pulmonary disease, inpatient care, and the acute alcohol withdrawal syndrome. Go to annals.org to read this hospital medicine update and those in other specialties. Also in this issue is a recommendation on cervical cancer screening from the U.S. Preventive Services Task Force. To develop the recommendation, the task force considered evidence on liquid cytology, human papillomavirus testing, and a computer model of optimal screening ages and intervals that has become available since the task force's 2003 recommendation. To briefly summarize the recommendations, women 21 to 65 years of age should get pap smears every 3 years. After age 30, testing for human papillomavirus can extend screening intervals to every 5 years, but HPV testing should not be used to screen before age 30. Women for whom the task force advises against cervical cancer screening are women younger than age 21, women older than age 65 years who have had adequate prior screening, and women who are post-hysterectomy and have no history of high-grade precancer or cervical cancer. Go to annals.org to read the full guideline, to test your knowledge with an associated CME quiz, and for patient education materials. You will also find an editorial that discusses this recommendation, as well as the joint guideline from the American Cancer Society, American Society for